Hi all.
Hello.
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 Hello, sir. Am I audible?
Yes, ma'am, you're audible.
Okay. Share the link of today's class. Okay. Geetu ma'am, have you joined? No, she hasn't joined yet. Hi. May I know who's this?
Yeah, myself, Dr. Deepak Agarwal.
Yeah. You texted.
Yeah, okay, ma'am.
Shall I wait for some more people to join?
Yes, maybe, ma'am.
Yeah. Okay. How are you doing, Dr. Deepak? I mean, having a tough time with the kid, is it?
Yes, ma'am. I'm having a tough time. Actually, booked for EDAC,
Yeah.
then a small kid, then booked for BCBR course. I'm in medical college, so booked for
Okay.
that. Then booked for IDRA Part 2 also.
Okay.
So,
Okay.
so
That must be
kind of very much busy.
okay. I've just posted the link in the group. Let them join if some are joining, and then let's start. Wait
Yes,
for
sure,
2
ma'am.
more minutes.
Yes, sure.
Okay. Geetu ma'am, have you joined? Hello. Okay. Geetu ma'am, have you joined? Okay, for today's
Yes,
session.
ma'am, I joined.
Okay. For today's session, Dr. Deepak and Dr. Geetu ma'am has volunteered to be the participants, and Geetu ma'am will be with us for somewhere around 15 minutes, say. And we shall start with the session, and I shall not wait for much time because it's already 8:10. So, for any of the third session or the clinical anesthesia viva session, you will be given a case scenario and you will be asked to brush it up for at least 5 minutes or 2 minutes or so. So this will be the case scenario which we are going to discuss today. Ma'am, are you able to see? Geetu ma'am?
Yes, ma'am, I can see.
Yeah. Can you please go ahead with the case history and then you brush it up for 2 minutes and then let me start asking the questions.
Okay, ma'am.
So he's a 69-year-old male patient who is a known diabetic on insulin therapy for around 20 years. And he's a hypertensive on telmisartan, amlodipine, and metoprolol. He's a known coronary artery disease patient who underwent PTCA to LAD just 5 months back. And for that, he's on aspirin and clopidogrel. So he's coming with a complaints of fatigue and excessive weight loss. And on evaluation, he's found to have a left renal cell carcinoma. The growth is limited to kidney, and he is posted for left laparoscopic nephrectomy. And how will you proceed?
Okay, ma'am.
All of you can think about how to present yourself in the examination, or you can write it down also, because you'll be given 2 minutes to think about how you are going to answer the question. If you're done, you can start answering.
Okay, ma'am.
Okay. This is not about answering each and every point. It is just about even if you're going for the examinations, it is on the day how you present. So it is you can give it fluently. It is not you should remember this point, that point, like that.
Okay. So ma'am, first I would like to go with the history and physical examination.
Okay.
For pre-anesthetic assessment. So patient is a diabetic on insulin. So I would like to ask about that history regarding whether he is regular with his medications and any peripheral neuropathy is there, any end organ damage is there, and any history of past DKA since he is on insulin. For any history of past DKA admissions, and how much is his blood sugars right now, and is he checking regularly? And regarding hypertensive, that also I would like to ask about the end organ damage now. Any hypertensive and diabetic nephropathy, and since he's on this one metoprolol, amlodipine, and telmisartan, he's on triple antihypertensives. I would like to ask about the compliance to the medicine also. And next comes the coronary artery disease, and it is very recent. PTCA to LAD 5 months back, which comes in major risk, ma'am. So I would like to ask about the functional effort tolerance post PTCA, and before PTCA, what was his symptoms and complaints he had, whether he got relieved of the symptoms after PTCA, and is there any exertional angina present, or and aspirin and clopidogrel, he's on DAPT. So that needs to be stopped. Aspirin, if it is 75 mg, we can continue. Clopidogrel needs to be stopped before surgery for 5 days minimum. So regarding these histories,
how will you risk assess these patients? What criteria would you use to assess the risk in these patients, and how will you categorize them as like high risk or intermediate risk? What is the risk yeah, can you elaborate the least revised cardiac index?
Yes, ma'am. There are 6 factors in that. Past history of cardiac failure, past history of IHD, patients who are diabetes on insulin, create more than 2, and major surgery, and CVA, history of CVA. These are 6 factors. Each carries 1 point each.
Okay.
So even if the risk factor is 0, they have a major adverse cardiac events risk is 3. One risk factor carries 6%. More than 2 risk factor carries around 9. More than 3 risk factors carries around 13% major adverse cardiac events risk.
Yeah, that I'm aware of, and there are very many guidelines which says like risk associated with these as 13% or so, but this is which I took from Miller, which says like if it's 0, it is 0.4%, and you can give a reference source as well if you like quote unquote Miller per se, or you can get it from an European guideline and then say this is what the European guideline says. Mostly they do not ask about how much percentage which is involved. They just ask about the points which are pertinent. Do you know any other risk stratification scores for coronary artery disease patients undergoing non-cardiac surgery?
Ma'am, Goldman risk that involves some
okay. And these all scoring systems will be asked in the ICU session. Okay, but they'll definitely ask scoring systems. So you should be very well versed with ASA and Goldman and all. And if at all they probe and ask you if there are any more indices per se, you can tell about DETSKI. And these are like not quite often used indices, but these are the indices. ACS NSQIP is given in AHA guidelines as well nowadays. So you can actually go through this. This is actually a net derived index, and it is given as a net calculator only, not easily available. And MICA and DETSKI are just the name. If they ask, you can just mention it. And ASA they ask about in detail. Okay. And do you know any categorization of surgery per se as low risk, intermediate risk, high risk in regards to the risk of major adverse cardiac events?
Yes, ma'am. Low risk involves only superficial surgeries, which can be like cataract, breast surgeries, and hernia. All those things comes in low risk surgery. Intermediate is like extra compartmental surgeries. Major is intracompartmental, which involves major fluid shifts and blood loss. So this nephrectomy comes in intermediate risk.
Okay, so this risk of NACE is independent of what the anesthetic procedure is used, and it is solely dependent upon the surgical risk only and not on the anesthetic risk factors. So coming on to perioperative drugs, which are all the drugs you would like to continue and which you would like to stop in the perioperative period for this patient?
Yes, ma'am. For this patient, I would like to stop telmisartan 24 to 36 hours before surgery because it is an angiotensin receptor blocker which can cause profound hypotension after induction.
Okay.
So I would like to ask him to continue beta blockers, ma'am. It is recommended if he is on chronic beta blockers, it should be continued for a IHD patient. And amlodipine on the day of surgery he can take. And aspirin 70, if he is on 75 milligram aspirin, he can take. Clopidogrel should be stopped 5 days before surgery. On the day of surgery, and the insulin, I have to, it depends upon the regimen of insulin, ma'am. If it is long acting.
For all our practical purposes, if the patient is on nilperoral, we can withhold the insulin, see for the random blood sugar and adjust the insulin accordingly.
Okay.
We can switch on to short acting and adjust the insulin accordingly. What are all the investigations which you like to do in the patient?
Okay. So investigations, ma'am, I would like to ask all routine, like for complete blood count and RFT, electrolytes, since he's on telmisartan. Serum electrolytes, I would ask, ma'am, and FBS, PPBS, whether his sugars are under control, and ECG, chest X-ray. Since it is a major surgery, I'll ask for LFT also. And coagulation profile is very much important.
Okay.
Uh,
Would you
and
like to go for an echocardiogram if it's taken
yes,
prior 2 months back? Would you like to repeat the echocardiogram?
yes, ma'am, I would like to repeat it.
Okay, say, I mean, any surgery, like if it's like 2 months, but the effort tolerance of the patient has not changed much, then we need not repeat it. If the patient has got a significant effort tolerance difference, then we can repeat it, because our therapy depends upon very much on the effort tolerance as well. It's not like if you go to the European guidelines, there are clear say like, you repeat it when and you don't repeat it when. Okay.
Okay.
Okay. Okay, how would you proceed with the anesthesia in this patient?
Ma'am, since it is a laparoscopic nephrectomy, my plan of anesthesia will be like general anesthesia.
Okay.
So the previous along with these all the drug recommendations, the previous night I would ask for an NPO for 8 hours.
Okay.
And since it is an
For 8
IHD
hours,
patient,
8 hours for 8 hours for
solid
6 hours.
6 hours.
6 hours for solids. Okay, let us be clear with all the NPO guidelines. 6 hours for solids, 4 hours for vessel, and 2 hours for any clear liquids. Okay. Okay.
I would not want this patient to be very anxious, because tachycardia will compromise his myocardial oxygen supply demand. So the pre-op night, I would put him on any anti-anxiety.
Okay.
And next day morning, my OT preparation is like, apart from the general RB preparation and drugs, I would keep a cardiac drugs ready, like all the antiarrhythmics, beta blockers, and defib, and I would anticipate any cardiac events during the surgery. So I will
Okay.
prepare the OT accordingly. I'll keep the defib charged and all the cardiac drugs ready. And so I would take 2 whiteboard IV. So I will give a good amount of fentanyl, 2 to 4 mics of fentanyl, and
What is your
glycopyrrolate
induction agent of choice in this patient?
etomidate.
Okay.
Etomidate 0.3 milligram per kg.
Okay.
And I would go for my relaxant agent will be Vecuronium.
Okay.
Since it is cardiostable, I would go for Vecuronium.
Okay.
And to avoid intubation, the scopy should be very fast, and it should not cause too much of tachycardia that will compromise his
How
cardiac
fast it
perfusion.
should be? Less than 15 seconds. Okay. Yeah. You continue.
So to suppress the scopy response, I would after giving induction, I would give 1.5 milligram of lignofen for this to decrease scopy response. And once I secure the tube, then my maintenance will be on isoflurane. Isoflurane and the graded doses of fentanyl. And
okay. What are your pain management strategies in this patient?
Multimodal, like I would give paracetamol and opioids. Fentanyl I would give intermittently.
Okay. For the post-operative period, and they have like for retrieving the kidneys, and they've made an incision in the left phalansteal they have given. And how would you how would you go for the pain relief in such cases?
We can go for USG guided tab block.
Tab block. It need not be. It is like you give a tab block, or whether it may be landmark guided or any ultrasound guided. You just give it as a. Whenever you say like combine with the regional also, it will be better. Okay. So how would you monitor intraoperative monitoring? What are all the strategies you would like to have in this patient?
Basic standard monitorings like ECG. ECG, I would select, since it is a cardiac case, I would select lead 2 and lead B5 now.
Okay.
And SpO2 and NIBP, ETCO2, and arterial line.
Yeah, I mean, you can manage with, arterial line then.
Then temperature monitoring. No?
Okay. Would you like to monitor the urine output?
Yes, ma'am.
Okay. So whenever your time is up, you just tell me, like when you want to go, you just let me, remind me so that I'll relieve you, ma'am. Okay. So monitoring per se, even like Miller says one value and Stolting says the another. The lead 2 is more important for the arrhythmias detection, as well as it detects the inferior wall ischemias to a maximum extent. So, but when you combine lead 2 and V5, it actually gives around 80% of the ischemia detection. And when you combine these three leads, you can actually detect the ischemia somewhere around 97 to 100%. So these, as you said, the invasive blood pressure monitoring, it's not, we are not, we can guide the therapy upon B2B basis with invasive blood pressure monitoring. And fluid therapies, we actually do not aim for the fluid therapy with the CVP because it may be misleading. And TEE, not in this case, but whenever you are given a case which is like involving a massive fluid shifts, like you say, a Whipple's in a very complicated heart failure patients, where you want to rule out like guide volume on a B2B basis, only then we can tell about the probe. Else, in this case, it's not at all indicated. And temperature monitoring is often the one, and the urine output monitoring is often the one which we would forget, and those has to be kept in mind, and like it should not be left alone. And they may ask about the CM5 configuration because this is what is used in most of the cardiac patients. So they may ask about where do you keep the lead. So the right atrial RA lead, right arm lead is kept in the manubrium. The left arm lead is kept in the V5 position, and the neutral lead is kept somewhere in the left shoulder or wherever we place a convenient position. So the CB5 is kept for the thoracic cases, but in cardiac cases, whenever they ask what configuration you may keep, we can actually tell them I'll keep a CM5 configuration. Okay, for monitoring, intraoperative monitoring. In clinical cases, this all the things which they may ask. So and perioperative, continuing the drugs, as you said, perioperative beta blockers, diuretics, and AC inhibitors or ARBs. If it is started for heart failure, then you can continue. But if it is for the antihypertensive measure, then we should withhold because of the risk of persistent intraoperative hypotension. And if the cardiologist has started this patient on prophylactic bridging of low molecular weight heparin, 0.6 ml OD, then how would you go about in this patient for the perioperative management of LMWH? Hello, Gitu? Okay, I think she got disconnected, isn't it? Gitu, ma'am? Deepak Agarwal sir, is it okay if you can volunteer from here?
Yeah, sure, ma'am.
Yeah.
So if the patient is on prophylactic dose of anticoagulants, low molecular weight heparin, I would like to stop it 12 hours before the surgery.
Okay. Okay. Would you continue aspirin with this patient?
Yeah, and then I like to continue it after 24 hours of surgery. I like to restart the low molecular weight heparin.
Okay. In this case, we are because the patient has got a drug-eluting stent, and it is just 5 months past the drug-eluting stent. What is the most dreaded complication you are afraid of while starting the clopidogrel?
The most dreaded complication, if the patient is having a drug-eluting stent and it's less than 6 months, then the most dreaded complication is the restenosis or the rethrombosis. The patient again can have MI.
Okay. What is the the recommended duration for a patient with drug-eluting stent to undergo a non-cardiac surgery?
The best is 12 months. If the patient has underwent 12 months before the drug-eluting stent, then it's safe to stop the DAPT. But between 3 to 6 months, between 6 to 12 months, we have to judge the risk assessment ratio of the surgery and stopping the drug. Then accordingly, we can stop the drug.
Okay. But what about the CABG?
For CABG also, it's 1 year. 12 months after CABG, we can stop the DABG.
No, if it's preferably after 12 weeks of CABG. If the vascular grafts are okay, it's preferably 12 weeks after a CABG, and elective non-cardiac surgery can be done. And if at all, it's like a time-sensitive surgery. And all, you may be asked about, so what's a time-sensitive surgery?
Pardon me?
What is a time-sensitive surgery? What is an urgent surgery? And what is an emergency surgery?
Okay, so the urgent surgery is
emergency surgery is anything which is involving a limb ischemia or a bowel ischemia or any organ damage or potential limb salving procedures which has to be done within 6 hours. And any procedure which is like still sensitive, but it can be taken from 6 to 24 hours. Within 24 hours, if you take, it's an urgent surgery. Any surgery which is like, which you can wait for 1 to 6 weeks, say like a CA breast, it has been diagnosed, but the patient is like just put on a drug-eluting stent. If you can wait for a month, and like, but the risk of metastasis is more if you wait for more than 6 weeks. So anything between 1 to 6 weeks, and the oncological surgeries, they come under this time-sensitive surgery. So this nephrectomy, it will be a time-sensitive surgery, because if you leave it as such, it may have an invasion into the IVC or renal vein as well. So time-sensitive surgeries are one. Most of the oncological surgeries fall into that category, and 1 to 6 weeks if the patient can wait for. And elective surgeries are like indefinite period the patient can wait for, say lipoma, excision, or sorts of stuff. Okay.
Yeah. Okay.
Okay. And do you know anything about intravenous antiplatelet agent bridging?
Intravenous antiplatelet bridging.
Agents bridging. Okay, so any patient who see, if the PCI, if the drug-eluting stent has been placed for acute coronary syndrome following an ST segment elevation MI or non-ST segment elevation MI, if it is placed for a acute coronary syndrome, then the dual antiplatelet agent must be definitely continued for 12 months or 1 year. If the drug-eluting stent, the risk of thrombosis is very high, but the hemorrhagic risk of the surgery is actually intermediate or low, then you can go for intravenous drug antiplatelet agent bridging, which is commonly done with tirofubin or etifibatide. There is a guideline from the European guidelines, and you can go through it as well. Still, this is like, they may ask or they may not ask, but it is like wise to know it, because if they ask, we can have a heads up in this. So intravenous antiplatelet agent bridging is done either with, can you all mute yourself now? Like, I'm getting a lot of so intravenous antiplatelet agent bridging, it's done either with tirofubin or etifibatide or cangrelor. Cangrelor is not available in India, so I can go with tirofubin. So you would see that picture which is given in the European guidelines, and it will be easy for you to answer those questions. Okay.
Sure.
So okay. So you have to continue statins if the patient is on that. So any, do you know any guidelines which says you should not beta, any study which says you should not start the beta blockers just before the day of surgery?
POISE trial.
POISE trial. Yeah, that says like you should not start the beta blockers. Why so? What is the inference from the study?
Because the patients who were started on the beta blockers like a day prior to the surgery, they had
they had more risk of stroke. No issues. They had more risk of stroke, and mortality, but lesser risk for myocardial infarction. Though the myocardial infarction rate was less, they actually had a more risk of stroke and mortality. Hence, starting the beta blocker or starting aspirin on the day just before surgery for risk optimization in the cardiac patients, it is not at all recommended. And starting them on clopidogrel or any calcium channel blockers perioperatively, like immediately, is also not recommended. And okay, so can you tell something about what are your goals or the myocardial grid cardiac grid you would like to mention in the patient, any cardiac patient undergoing non-cardiac surgery?
Ma'am, like
Or
my goal would be
myocardial protection. How would you aid the myocardial protection in those patients?
so my goal, first of all, my goal would be to keep the balance between the myocardial oxygen supply and the demand.
Okay.
So for that, I'll keep the oxygen supply more than the oxygen demand. So increased demand could be because of tachycardia, if there is increase in diastolic blood pressure, or increase in systolic blood pressure. Decrease in diastolic blood pressure, increase in systolic blood pressure, tachycardia. Then if there is a pain, anxiety. Then there are some times during surgery where these patients can have increased demand, like intubation, laryngoscopy, during surgical incision. So we have to take care of all these times. So we need to keep the demand low to prevent the myocardial infarction.
Okay. What are the reasons for decreased supply in these patients, or perioperatively, what are the causes?
So decreased supply could be because of hypovolemia, like then decreased contractility of the cardiac contractility is less. Then the patient is anemic, then the oxygen supply will be less. The cardiac output is less, contractility is less. Then
for obvious reasons, hypotension, which you told, like decreased contractility, it's hypotension.
Yes.
And surgery, it's itself a hypercoagulable state. So there can be any thrombotic manifestation in the perioperative period, and also any shear stress in the vascular wall can lead to plug rupture. Okay. So these are all, I've just given it, whatever you have said, I've just given it as a presentation in PowerPoint slide here. That is all. And what are all the places where you anticipate the patient might decompensate in the perioperative period? Or what are all their specific goals? As you told, the intubation. Then can you proceed from there?
Yeah. So first of all, before intubation also, like the patient can have pre-op anxiety. So for that we need to give the anti-anxiety drugs like midazolam. Then the patient, while induction, the patient can have hypotension. So we need to choose a drug which avoid hypotension. Then at the time of laryngoscopy and intubation, the sympathetic response can cause hypertension and tachycardia. So we need to choose our agent. We can give esmolol, which is a short-acting beta blocker. We can use Zylocard, then at the time of surgical incision, we need to give adequate preemptive analgesia. Then the patient we need to avoid hypovolemia. We need to avoid anemia. Then at the time of extubation also, we need to avoid the stress. And post-op analgesia is very much important in these patients to prevent myocardial infarction.
Okay. Can you tell me about what is the HP trigger for patients of cardiac surgery cardiac patients undergoing non-cardiac surgery? How would your blood management be in these patients?
It's usually 10 milligram per deciliter.
Okay.
So
what's your take on the glycemic control? Would you have, how frequently would you monitor, and would you like to keep him on insulin in the perioperative period as well?
So for the glycemic control, we keep the patient fasted, and we'll check the morning fasting blood sugar, and accordingly we'll start the drip. We'll start the IV fluid, and then every hour we need to check the blood sugar during intra-op period, and according to sliding scale, we can manage the intra blood sugar, or we can start continuous insulin infusion, and accordingly blood sugar we can titrate that insulin infusion.
Okay.
So we need to keep the blood sugar between range of 140 to 180 milligram per deciliter.
Okay. Since this patient is on, like, a patient who is 69-year-old with a cardiovascular comorbidity or a known coronary artery disease patient, would you like to do undergoing an intermediate risk surgery? Would you like to do a troponin preoperatively, or what is the role of troponin in these patients? And how would you monitor troponin in these patients?
The role of troponin, if the patient has got no fresh ECG changes, the MET score has not changed from the previous value, then we need not get the troponin done preoperatively. But if the patient, sorry.
No, there is like Sumaira.
Okay.
Someone else is talking.
Okay, sorry.
Okay.
So if the in intra-op period, we need to detect the myocardial infarction through the ECG changes. And if the patient, if we are suspecting the patient can have a myocardial infarction in the intra-op period, then we should advise troponin, T-troponin I, and then accordingly we can manage the patient.
Okay, but the recent guidelines have changed. So any patient who is undergoing a cardiac surgery, any patient who is more than 45 years old with a known cardiovascular risk factors like known CAD or known ischemic heart disease or known heart failure, and any patient who is more than 65 years old without any cardiovascular comorbidities, who is going to undergo an intermediate or high risk surgery, you have to do a preoperative troponin 24 hours prior to surgery, and you have to do a troponin 24 to 48 hours, 24 hours and then 48 hours after surgery. So this is the recent guidelines from the European guidelines as well as from the AHA to detect the myocardial injury following non-cardiac surgery. So any patients more than 45 years who has known cardiovascular risk factors, and any patient more than 65 years without any known cardiovascular risk factors, a preoperative troponin and postoperative troponin at 24 hours and 48 hours is advised to detect the myocardial injury following non-cardiac surgery. Why preoperatively it is advised? Because with advanced age, the troponin actually increases, and with renal insufficiency also the troponin increases. So to find out whether these patients have got a preoperative elevation or not, then we have to do a preoperative troponin as well. So this is the case scenario. This type of case scenario you will get in the fourth session, which is the ICU part. Okay, so the same patient during the intraoperative period, he had an extensive blood loss and multiple transfusion in the perioperative period, and on second postoperative day had a troponin which is more than 99 percentile elevated, and the ECG shows this. So how will you proceed? The vitals are given. He's conscious oriented. He's not having any complaints per se, but upon evaluation, the heart rate was around somewhere around 120, but in the ECG, it's not so. The BP is somewhere around 160/100, and the ECG taken after some time showed this rhythm. Anyone else would like to volunteer, or Deepak Agarwal sir, you're okay with continuing?
Yeah, I can continue, ma'am. If anyone else is going to volunteer, it's fine.
Anyone else?
Madam, I would like to volunteer.
Yes, sir. I mean, it's fine, sir.
Okay. Thank you.
Yeah, so the same patient who was a 69-year-old had underwent a nephrectomy, and during the nephrectomy, he had an extensive blood loss and had multiple transfusion in the perioperative period. And on second postoperative day, he had troponin more than 99 percentile of the upper limit of normal, and his BP was somewhere around 160/100, and his ECG showed this rhythm. So how will you assess the patient, and how will you go about it? And what is this actually?
The ECG has shows T wave inversion in AVL.
Yeah.
And lead 1.
Yes.
Suggests
the
lateral myocardial ischemia.
The T wave inversion is also there in V4, V5, and V6.
V6.
Any T wave inversions in lead 3, AVR, and V1 are not significant. Okay, but this patient has got a lead. So you continue this. So then let me rephrase it later.
Fine.
Yeah.
He shows significant T wave inversion, and his troponin level is also increased. He's hypertensive and having tachycardia.
Yeah.
It indicates to perioperative myocardial ischemia.
Okay.
Should we should start managing this patient with the revisiting our pain prophylaxis. Should have adequate analgesia.
Okay.
Preferably, I would use morphine for him, which decreases preload as well.
Okay.
Supplement, and the patient should be, if this, sorry, I've forgotten how much time has elapsed after the surgery. If
it's 48 hours after the
48
surgery.
hours.
Second post-operative day.
Second post-operative would start low molecular weight heparin and antiplatelet agents.
Would you like to see the drains? Would you like to know the value of the drains which they had kept?
Yes.
Okay,
if the drain is insignificant, then would start antiplatelet agents and unfractionated heparin along with the oxygen, maintaining normothermia.
Okay.
Target heart rate would be 60 to 80.
Okay. What drug would you give him for that?
I would give a beta blocker.
Okay.
Either esmolol or
he was on metoprolol previously. Would you like to continue?
So I would yes, madam. I would like to start metoprolol.
Okay.
And
would you like to manage him in the intensive care unit, or would you or a high definition unit, high dependency unit, or would you like him to monitor in the ward itself? Or
no, would like to shift him in the high dependency unit, and nitrates can be given.
Okay.
Although they do not increase survivability, but those having chest pain, they are useful.
Okay, so this patient did not have a classical chest pain, or this patient did not have any echocardiographic definition of an MI. And even if the ECG changes are not there, just with the troponin elevation, we can diagnose this myocardial injury after non-cardiac surgery. So this myocardial injury after non-cardiac surgery is an elevated postoperative troponin, more than 95% of upper limit of normal, or HS troponin, high sensitive troponin, more than 14 nanogram per liter. And if you have a preoperative troponin, any value which is more than 20% rise from the baseline value is considered significant. And all the myocardial injury following non-cardiac surgery should have the occurrence within 30 days. In this patient, it had occurred within 2 days. So the mechanism is usually ischemic, where it be a plug rupture or a demand supply mismatch. And there may not be any clinical symptom for the patient. The patient may just present with tachycardia, hypertension, or the patient can just have a troponin elevation alone. The patient need not fit in for any definitive definition for myocardial infarction, but the patient will have troponin elevation. So it is, if the ECG changes are not there, it is just a myocardial injury after non-cardiac surgery. Only because there is a non-ST segment elevation MI features, then you say like it's a perioperative myocardial infarction. So when is this perioperative myocardial infarction more common?
More common 24 to 48 hours post-op.
Okay.
That's the time when interstitial fluid is mobilized.
Okay.
Increasing preload is the time when the patient becomes active. Is the time when analgesias are tapered off, so the patient starts having some pain.
Okay.
It's so also the time when the patient becomes more alert and
ambulation happens. Ambulation happens and all that. Okay. So whenever they ask about what are the risk factors for perioperative myocardial infarction, you categorize into preoperative, intraoperative, and postoperative. Always categorize it into patient-related factors, surgical factors, anesthetic factors, and in the postoperative also, you like categorize it into the patient-related factors and the post-surgical factors. Okay.
I know.
Okay. So this myocardial injury following non-cardiac surgery is like the evidences are quite recent, and I would urge everybody to continue. So if at all you are given a scenario in the in this kind of similar system, and it says if the patient is say the pulse rate is somewhere around 130 per minute, and the blood pressure is somewhere around 90/60. So how would you manage?
90/60.
And the pulse rate is 130 or so.
Patient is likely to be hypovolemic. I would assess the patient's volume status and give fluids. And if the patient is anemic, then instead of fluids or along with fluids, I'll give PRBC also. Okay.
So if the patient, in spite of you giving fluids, vasopressors, and you've done coronary, you've done a bedside echocardiogram as well, and he is showing a new regional wall motion abnormality in the area of left anterior descending artery, and he's persistently hypotensive in spite of your measures. So what would you think of?
I would think of a fresh onset of a fresh myocardial infarction.
Yeah, then if it is persistent cardiogenic shock, if you're given a scenario in an ICU where a patient post percutaneous coronary intervention has a persistent ischemic feature, then you would actually go for coronary angiography. And if the patient is hypertensive, as in our case, you say them like you can start on AC inhibitors, like hypertension with tachycardia, beta blockers. If it's a pure myocardial ST segment elevation MI, then it's a guideline directed therapy, whether you have to go for a coronary angiography or so. It depends upon the case scenario. And if it's a persistent cardiogenic shock, then you go for coronary angiography. Okay. Okay. So a note on these patients, if they are posted for coronary artery bypass surgery. So how would you go about this patient? Like a 69-year-old, he has got a double vessel disease, a left anterior descending, and OM1 grafting must be done. So how would you go about it? For CABG, they may not ask about each and everything in detail. So I've just given a hint of what they may ask, that's all. So you can, if you're okay with it, you can continue, sir.
Sorry,
no problem. Anyone else who would like? No issues. Anyone who would like to volunteer? No, they may. There are these topics in podcast also. They may ask. That's why, in particular, I've taken this topic.
I can try, but
no. It's all about trying, sir. It's all about trying. No issues. You can just try. I've given a hint also for you. Yes, sir.
Yeah.
I'm not able to.
Hello.
I'm all.
Yeah, I'm
not
able.
I try? Yeah, yes, sir. Yes, sir. Sure.
Yeah,
I've actually given a hint also, like how you can go about an answer. I've just given the slide also. You can just see that, and then whatever you remember, you can say.
So now we have a patient who was like same patient. We have instead of renal surgery, is now posted for a CABG.
Yes.
Yeah. So the patient again, I'll start with proper assessment of the patient, which covers the history. In the history, I'll go for a restratification from a cardiac point of view, and his medical history. Then his effort tolerance. I like to evaluate that, and accordingly, examine him, his basic parameters, and then I will like to investigate him thoroughly. From a major cardiac surgery point of view. In the investigation, complete blood profile, renal profile, then I'll like to go for ECG, echocardiography for this patient to know the status of the heart and any wall motion abnormality, any valvular involvement, especially aortic and all. And I'd like to know current ejection fraction, though it will give me an idea about at rest. And then, if required, I'll like further restratification evaluation, which from met current status, whether it is up to 4 or not, or then whether if it's possible, I'd like to go for a 6 minutes walk test.
Okay.
And obviously, if I have a facility, I'd like to go for a CPET cardiopulmonary evaluation testing,
Okay.
which will give me an idea about his current cardiac and respiratory, both simultaneously, both status before posting him for surgery.
Okay.
After completely evaluation and investigation, I will take a. I'll like to post him for a surgery with a preparation. His current medical status is control about glycemic control and BP control. These are the two controls which I like to posting for a surgery.
So your audio is breaking.
Previous night, I like to have a proper control, glycemic control and
Okay.
hypertensive control before posting him for a surgery.
Okay.
If required, changes in his anti-diabetic drugs and antihypertensive drugs will be done. I like
Would you
to
like
hold
to continue? Yeah.
I'd like to hold the telmisartan which he's on previous night.
Okay.
Because it may disturb my intra-off. I may have to face some severe hypotension to my anesthesia at various stages. And I'd like to hold I'd like to keep him NBM for 6 hours. And next day morning, I like to post him early morning. I like to do his know his BSL before.
Would you like to provide
fasting.
an anxiolysis the previous night?
Yes, previous night I like to provide him a angiolysis of maybe 0.25 alprazolam drug. And
would you like to continue the clopidogrel if he was on previously?
No, madam. As patient is on a dual platelet, here I like to pick him on a bridging therapy to stop. I can continue aspirin and stop the clopidogrel. Here I like to put him on a LMWH. And I'll see to it that last dose goes at least 24 hours before. Like today morning, if I give a dose of LMWH, next day morning patient will be posted for surgery.
Even for a prophylactic dose, you would like to wait for 24 hours, is it?
Prophylactic dose, 12 hours.
12 hours. Wait,
okay. 12 hours. Previous night I can give the dose. And then since it is a major surgery, I like to prepare the theater properly, where I'll see my all the emergency drugs, the monitoring which I had planned, and everything. I may like to involve my senior also, along with the surgeon, and I'll check my consent. I'll have an informed consent with the patient's relatives.
Okay. Would you like to reserve blood products?
Yes, ma'am. I like to reserve 2 PCVs and 4 FFP for this case. Okay. And then with the proper preparation and all, I like to take the patient for a surgery.
Okay. Provided his ejection fraction is all right and his valvular lesions are okay, what is your induction agent of choice in this patient?
Here, ma'am, I like to go for a opioid induction.
Okay.
With fentanyl and midazolam. Okay. With a pre-oxygenation properly, with a monitoring in situ. Before induction, I like to have an arterial line in place and central line in place under local anesthesia and anxiolytic drugs. Okay. And then after that, the induction will be guarded.
Once you have given like before that the mask ventilation was all right or the bag was filling properly, but once when you have given say 250 to 300 mics of fentanyl, you have a difficulty to ventilate. What does it signify?
Difficulty to ventilate signifies that it may be a jaw fall, it may be a tongue fall, obstructing the upper airway. So I'll keep a close watch on his BP, and I like to use either a nasal or oropharyngeal airway and try to ventilate the patient.
No, it occurred typically after fentanyl doses. Before that, there was
the fentanyl is known for a tight chest
rigidity. Okay. How would you manage that? How would you manage that?
If the BP is okay, I like to take the patient deeper, either with a small adding dose of etomidated or an inhalational agent, sevoflurane. And
what is a paralyzing agent of choice in cardiac patients?
In this, I like to go for a vecuronium, ma'am.
What is the dose of vecuronium use?
0.8 to 0.1 milligram per kg loading dose. Once I confirm that I am able to ventilate the patient, and then properly taking 3 minutes for relaxation to occur, adequate relaxation to occur, and if required, I'll give a I'll give a xylopod dose to prevent the laryngoscopic stimulation, and then I'll secure the airway and maintain the patient on oxygen and sevoflurane, oxygen air sevoflurane combination. With a vecuronium drip, and I'll balance the requirement of I'll keep all the drugs like NTG and dopamine drip and NORAD drip ready beforehand only prepared, and I'll see to it that my goal of preventing hypoxia and maintaining normal tension is achieved. If required, I'll like to use the combination of fluid depending on central venous pressure, fluid and pressure response. I'll achieve the normotensive stature. And then as far as sugar goes, I like to assess his sugar every hourly to keep the glycemic control well in hand. And temperature management will be my important concern, so that I'll try to prevent hypothermia as much as possible. Normothermia will be my aim, unless my surgeon wants to go for a on pump
CABG. Okay, so what do you expect when the patient is done a sternotomy? What are the hemodynamic changes which can happen?
Yeah, sternotomy, after the skin incision, sternotomy is something which gives the maximum pain. So before that, I'd like to give an additional dose of fentanyl, from 25 microgram to 50, depending on his blood pressure status and heart rate, before the sternotomy.
What is the dose of heparin you use to heparinize these patients for cardiac surgery? If they are going on pump?
Yeah, if they're going on a pump, then we give almost 300 units per kg.
What is the ACT target?
Dose. Our ACT I target around 150 plus minus 25. 3 times the rise in baseline is ACT.
Okay, the normal ACT is somewhere around 80 to 120 seconds, and you expect the ACT to rise around 350 to 400 seconds. Okay.
Yes.
So for any on-pump bypass surgery, can you enumerate the steps for cardiopulmonary bypass? Just the steps.
Yes, ma'am. So steps is once we have to prepare the pump. We have to apply the pump. Basically, units are input cannula, and then there is the rotator pump, and then there is the oxygenator, and to which you can attach inhalational agent vaporizer also.
Yes.
And the goes to the aorta. So surgeon inserts the cannula into the IVC and SVC, and then the blood comes to the through the filter. It comes to the oxygenator. Usually we use the membrane oxygenator preferred over the air bubble oxygenator.
Bubble oxygenator.
Yes, ma'am. Yeah, and then
there is one more component, which is a heat exchanger, because that's where the temperature is controlled, isn't it?
Controlled, yes, ma'am. Heat exchanger, and then the pump which gives the continuous flow to the output cannula. And if required, we can add blood or
mostly
to it.
The priming solution for adults is mostly crystalloids, and for the pediatrics it is blood. The priming is done with the blood. Okay, so which vascular cannulation is done first?
Yes,
is it the aorta or the right atrium or SVC IVC?
It's SVC IVC.
No, the aorta is done first, because any volume loss or any volume loss which is there during the cannulation, or any blood loss which is done inadvertently during the dissection, if you have an aortic cannula, you can directly go and give the priming solution there or
Priming
the
solution.
blood there, and you can have a effective circulating volume. So the first
Yes.
cannula which is done is the aortic cannula. So what are all the steps or the prophylactic measures you must take before the aortic cannulation, and what are all the complications which can occur during aortic cannulation?
Yes, ma'am. First and foremost is there should be a heparinization properly before the aortic cannulation, and then pressure should be very well maintained.
It should be 90 to 110 systolic only, because
because it can cause there are always chances of aortic dissection during the aortic cannulation. So which we'll have to keep in mind, and that's what I can think of, ma'am.
So one complication is what you have said, it's the aortic dissection. The second is hypotension and any volume loss during cannulation. The cannula can be it cannot be put properly, so hemorrhage and emboli from the ascending aorta. If there are any calcified plaques that can get embolized and can lead to embolic stroke. So those are the complications of aortic cannulation. Then the SVC or IVC cannula is done, and so as you said, the components of this cardiopulmonary bypass includes a venous cannula, which will take the blood from the. It can be an SVC cannula separately or IVC cannula separately, or it can be a single cannula into the RA. So any RA cannula will take the blood from there. It will store in the reservoir. Will be it's actually rolled over in the roller pump and then given into the heat exchanger. There it can be either cooled or heated through the oxygenator. It will actually, as sir said, it's to the membrane oxygenator. Bubble oxygenators are not used nowadays, and the carbon dioxide is actually taken out by the sweep gas. So if at all there is retention, the sweep gas rate must be increased and the carbon dioxide will be vented out. So the oxygenated blood is actually taken into the arterial cannula and it actually given into the patient. So what are all the methods by which the myocardial protection is aided in cardiopulmonary bypass?
Myocardial protection of importance.
I'm not able to hear you, sir. Sir, I'm not able to hear you clearly. Sir?
There is a connection problem from my side.
Now I'm able to hear.
Connection problem from my side.
Now I'm able to hear.
So potassium-rich cardioplegic solution is inserted to make the heart arrest and in the diastole.
The heart arrest, diastole.
And ice is sometimes used to reduce the temperature of the myocardium so as to decrease the CMRO2, oxygen consumption by the myocardium.
Okay. So at 22 degrees Celsius, the myocardial consumption actually comes down around 97% for at least 20 to 40 minutes. So that is the myocardial protection you aim for. So the hypothermia and cardioplegia are the myocardial agents which are used. And sometimes they may ask about the components of cardioplegic solutions which we may use. So it's actually good to go have a look in Deepak Tempe. They may not ask about what are all the what is the definitive milligrams, but the components like potassium, magnesium, mannitol, and all that. Magnesium. So whatever it's there, it's good to have just a note on the cardioplegic solution. So the graphs are done, and do you know any mnemonic for weaning from bypass? Or how would you wean the patient from bypass? Or what would you check? Or what would you check just before weaning from bypass? Or what are all the checklists that you will run?
Weaning will be once the surgery is done. My checklist will be temperature, hemodynamic stability, temperature, oxygenation. Then it will be good anesthesia cover.
Okay.
And and then ABG, and in which I will see acidotic status of the patient, and reverse of the hyperization by protamine.
What is the dose of protamine which you will use?
So I'll
Sir? Okay, the dose of protamine is actually 1.3 milligram per 100 units of heparin which is given. And there are also heparin dose response curves like from time since elapsed since heparin, and you can see what is the dose you must give. So most probably if you just say the protamine dose, they may actually leave. And this protamine is actually taken from the salmon fish sperm, and sometimes they may ask about this protamine reaction, like type 1 reaction, type 2 reaction, and all that. And if the patient has got, or they may sometimes ask, where do you actually give protamine if there is a severe pulmonary artery hypertension? So our primary idea is to hemodilute this protamine. So the best site to administer will be left atrium. And this is Romanov's CVP score for weaning from bypass, which is actually CVP. And C stands for cold, conduction. Cold is actually temperature management. Conduction is C for any conduction defects. C if the rhythm is sinus. Check for calcium, cardiac output, and cells is how is the anemia corrected. If the HB is okay, check for the coagulation parameters by ACT or PTINR or any point of test coagulation which you're applying. And V, ventilation, turn on the vaporizer, give a volume expander if it must be, and you visualize the heart. C for any like contractility is bad or good. C for the field. And P for predictors. Any predictors of hypotension. Any patient who was on previously telmisartan, or any patient who was on previous AC inhibitors or ARBs, they may actually have a systemic vasodilatation and be a predictor for to have a vasoplegia or so. So that's for the predictors. And give for protamine, and pressure is C for the how are the pressures maintained, and pressors is vasopressin or noradrenaline or phenylephrine, whichever you use. And if you have to pace, if the rate is too low, if you have to pace, then pace it. And check for potassium. So this is a CVP Romanov score for weaning from bypass. And they will not go into detail of each and everything, but they may ask you, like, as and when you describe, they may ask how you do wean from bypass. So that is how the exam will go. And
yes, ma'am.
it is not like they'll go in detail about everything, but this is just about, this slide just tell about how a CPB is instilled in, like, just a nutshell. This is how they asked me in the examination as well. They didn't ask each and everything in detail, but they asked about so many things as a whole, and they just saw if you know at least something in everything.
Got it, ma'am.
Yes. Okay. So if anyone has any doubts, kindly please ask so that let me clear it. And please read about troponin, new troponin guidelines, and the myocardial injury following non-cardiac surgery, and any post-operative management. No, and for whatever I've heard, both of you did not tell about the airway examination. So let us not forget about airway examination at any point of time. Okay.
Keywords.
Someone was asking something.
I was just asking, will you please repeat the mnemonics of reversal extubation before extubation?
No, that is weaning from bypass. It is Romanov's CVP score. Weaning from bypass. It is CVP. C has somewhere around 6 components. It is cold, cardiac output, conduction, calcium, cells, and coagulation. And V has, you have to start ventilating, start the vaporizer. You can use volume expanders if you want to, and you want to visualize the field and how the heart contracts, all that. So V stands for ventilation, vaporizer, volume expander, and visualization of the field. And P stands for what are all the predictors. Some patients may land up in vasoplegia post-op. So that will be a low cardiac output syndrome state. So there are predictors for hypotension in the post-bypass period. So those patients who have predictors, see for the predictors. You see how the pressure is. You put on the pacer and the pressors which the patient must get, and then is protamine and potassium. See, it's there in Miller. I can share a screenshot from Miller if you want to.
Yes,
Okay.
got it, madam.
Okay. Anyone has any other doubts or like want to clarify how it must be answered? I'll try answering it for you.
Hello.
Yes, sir.
Hello, ma'am.
Yes,
Hello.
yes.
Can you please repeat the perioperative troponin level?
Yeah. So the
Preoperative and
perioperative. Yeah. So actually, it is myocardial injury following non-cardiac surgery. Any patient who is undergoing more than 45 years with known cardiovascular risk factors, actually you must do a preoperative troponin and a postoperative troponin at 24 hours to 48 hours. Okay. Any patient who is more than 65 years of age without any cardiovascular risk factors who is going to undergo intermediate and high risk non-cardiac surgery, then we must do a preoperative troponin and troponin at 24 hours and 48 hours. A preoperative troponin is advised because a patient with renal insufficiency and advanced age nowadays have shown to have an increased troponin levels. So this baseline is taken as a like a marker. Any patient who has more than 20% elevation from this baseline is considered to be diagnostic of myocardial injury following non-cardiac surgery. And any patient who has got more than 99% elevation of more than 99% of upper limit of normal is diagnosed to have myocardial injury following non-cardiac surgery. And it should typically occur within 30 days. And the mechanism is ischemic. How it is different from perioperative myocardial infarction is myocardial infarction has a diagnostic criteria. If you go and look for the third universal definition of myocardial infarction, it should have a troponin increase, it should have an ECG change or an echocardiogram change, and the patient should have a ischemic symptom like a chest pain, retrosternal chest pain or so, or an effort intolerance or whatever. So the patient will not fit under any criteria except for the elevated troponin. All myocardial infarction is because of myocardial injury, but not all myocardial injury lands up in myocardial infarction.
Yes, ma'am.
Okay.
Okay, ma'am. Thank you.
Okay. So this is from the latest European guidelines, so they may ask. So Naren, so from the beating heart, sir has asked about beating heart. So in the beating heart, what these all remains common. So up to sternotomy, heparinization, ACT remains common, and vascular cannulation also. From the beating heart, what will happen is you can say you will heparinize, and they'll keep an octopus or a immobilizing thing on the LAD. During LAD stenting or bypass grafting, there may not be much of an issue because the anterior myocardium is just the octopus is just put there, and the rest of the myocardium works very well. Where you will have a hemodynamic perturbation is when they are going to do an OM grafting. So the heart is actually lifted up, and the axis of the mitral valve also is changed. So whenever you say that they are going to graft for OM, you say that you will just give a slight head down, and then you will actually load the patient with volume because there will be an mitral regurgitation because the heart is rotated and the axis is changed and the heart is actually lifted up. And you say you will give volume and keep a pressure. And once when the patient is stabilized, then I ask them to apply the octopus on the OM side, and then you will graft it. Rest all remains the same, except that the cardioplegia is not given. That is all. The pump will be on the standby, but they will be operating on the beating heart. That is all. Rest of it doesn't change. The pump doesn't come, but ACT comes, and you will actually apply for an octopus. That's what I'll expect in the examination. They apply the octopus, which immobilizes the particular portion, and when they the more severe hemodynamic perturbations occur when they are actually going for an OM grafting or an ALCX grafting. Okay. And if at all they ask about blood conservation strategies, you can actually tell them about tranexamic acid for any, even for CABG or for any cardiac patients undergoing non-cardiac surgery. You can actually tell them you will give a dose of tranexamic acid as a prophylaxis for controlling the bleeding. And that also must not be forgotten, because we have not went into the blood conservation strategies at all. Anyone has any questions? Shall we wind up the session for today?
Thank you very much, madam.
Thank you, sir. Thank you. See you all in the next meeting.
Thank you, ma'am.
Thank you.